Welcome to the Hospital Medicine Unplugged podcast.
Hello.
Today we're tackling a really critical topic, disseminated intravascular coagulation, or DIC. It's a complex and often life-threatening syndrome that, it challenges all of us in critical care and hospital medicine.
It really does. DIC is fundamentally this profound breakdown of hemostatic balance. It's an acquired disorder, happens inside the blood vessels systemically, and it's characterized by these two processes happening at once, which makes it so dangerous.
Right, the two sides of the coin.
Exactly. You get this widespread activation of coagulation, leading to microvascular thrombi forming everywhere, and at the same time, you're consuming platelets and coagulation factors. So paradoxically, you're set up for both clotting and massive bleeding.
That dual pathology, that's the core challenge, isn't it? It means the clinical picture can be incredibly varied. You might see just some subtle lab changes you pick up incidentally.
Or it can be fulminant,
Yes,
just
sir.
catastrophic hemorrhage, multi-organ failure developing incredibly rapidly.
And we really need to underscore the seriousness. Acute DIC, especially when it's triggered by sepsis or major trauma, carries these really high mortality rates.
Yeah,
You often see figures cited between, 28% and 42%?
that's right. Those numbers are sobering. It really drives home that recognizing this early isn't just good practice, it's absolutely vital for survival.
Absolutely.
And, our understanding is evolving. The International Society on Thrombosis and Hemostasis, the IST, they're really pushing towards a more dynamic, phase-based view. Their 2025 updates emphasize this.
So less of a static diagnosis and more of a process we need to track.
Precisely. We're not just looking for DIC present or absent. We need to think about pre-DIC, maybe an early subclinical phase, and then overt DIC.
And that means our approach has to be tailored, right?
Yeah.
Depending on the underlying cause.
Exactly. The underlying disease really dictates the phenotype, how it looks clinically. Take sepsis-induced coagulopathy, or SIC. SIC is typically characterized early on by aggressive microvascular thrombi. That's the main driver. It leads directly to organ dysfunction pretty quickly. Bleeding can happen, sure, but the primary killer in SI is often the tissue damage from those clots.
That's a key point. SIC is primarily thrombotic first. So how does that differ from, say, trauma-induced coagulopathy, CAIPA?
Well, trauma's different. TSI often hits you right away with profound bleeding. Think of massive tissue injury, factors getting used up incredibly fast, plus hemodilution from all the fluids we're pouring in.
So initially, it's hemorrhagic.
Very much so. But if the patient survives that initial onslaught, they can then shift later into a more prothrombotic state. So the big takeaway is, sepsis tends to drive microclots and organ damage first. Trauma often drives immediate massive bleeding first. Our initial management has to reflect that difference.
Okay, let's dig into the pathophysiology. For this audience, understanding the cascade helps make sense of the treatments. DIC isn't primary, it's always triggered. What kicks off that systemic chaos?
It starts when the coagulation system gets massively exposed to signals it shouldn't normally see systemically. The main way this happens is through the rapid release and exposure of tissue factor.
The initiator of the extrinsic pathway.
Right. Released in huge amounts by damaged endothelial cells or maybe monocytes that are activated by the injury or infection. The contact pathway can also get activated.
And the things triggering that release are basically the body's alarm signals in severe illness.
Exactly. You can group them into pathogen-associated molecular patterns from bugs.
Like LPS from gram-negatives?
Correct. And DAMPs, damage-associated molecular patterns, these are released during massive cell injury, like in severe trauma.
Our sources mention specific DAMPs, like extracellular histones in DNA, which are really interesting. They get released when cells just rupture on a large scale.
And they're not just markers of damage, they are actively procoagulant. They can directly activate parts of the cascade, essentially bypassing the normal checks and balances. It's like slamming the gas pedal down.
The immediate result being
Uncontrolled, excessive thrombin generation. Thrombin is absolutely central. It converts fibrinogen to fibrins systemically, driving those widespread microvascular thrombi. This massive thrombin burst just overwhelms everything.
But that high-volume clotting has a cost, right?
Yeah.
That leads to the consumption part.
Absolutely. The system is burning through clotting factors faster than the liver can make them, and using up platelets faster than the bone marrow can push them out.
So you get thrombocytopenia.
Right. Low platelets. And depletion of factors, which is why the PT and aPTT get prolonged. This consumption is what ultimately causes the bleeding tendency later on.
And it's not just using things up. The body's own anticoagulant systems are failing too.
That's crucial. The natural brakes antithrombin, protein C, tissue factor pathway inhibitor, they get consumed or cleaved by enzymes or just functionally shut down by the inflammation.
So removing the brakes while flooring the accelerator.
Exactly. A really dangerous combination.
Okay, if the anticoagulants are failing, what about fibrinolysis, the clot breakdown system? Does that kick in?
Well, it tries, but often it's actively suppressed, especially in sepsis. The inflammatory cytokines do two things. They amplify coagulation and they shut down fibrinolysis.
How does that happen?
Mainly through a massive increase in plasminogen activator inhibitor 1, or PAI1. PAI1 basically blocks the enzymes that break down fibrin. So by jacking up PAI1, the body prevents the clots from dissolving.
So thrombin makes the clots, PAI1 stops them dissolving.
Yeah.
The microthrombi just stay there, blocking flow.
Precisely. And that's key, especially in SIC. Those persistent clots in the tiny vessels of the kidneys, lungs, liver, that's what causes the poor perfusion, the tissue damage, the organ failure that leads to that high mortality. Understanding PI1 helps explain why organ dysfunction is often the main feature in septic DIC, not always massive bleeding.
Right. Okay, let's shift to the clinical side. What are the most common triggers we see in the hospital? Knowing the cause is key to stopping it.
Sepsis. Hands down, it's the most frequent cause, accounts for a huge chunk of acute DIC. Often bacterial, think staph or EOS or gram-negatives like E. coli.
But not always bacteria.
No, definitely not. You have to consider viruses too, like advanced HIV or even overwhelming fungal infections. Keep a broad differential.
And outside of infection, what are the big non-infectious culprits?
Major trauma is right up there, probably second only to sepsis. Massive tissue injury just floods the system with tissue factor and inflammatory signals, leading straight to that TEASE picture we discussed.
Okay.
Malignancy is another major one. Acute promyelocytic leukemia, APL, is notorious for causing DIC. It's a true emergency. And many advanced solid tumors can cause a more smoldering, chronic form of DIC.
We also can't forget the obstetric emergencies. Things like placental abruption, amniotic fluid embolism. They can trigger DIC incredibly fast.
Absolutely. Catastrophic situations requiring immediate action. And then there are less common but still important causes: severe burns, heat stroke, even some snake bites that inject procoagulants directly. The bottom line is always find and treat the trigger.
So, connecting pathophysiology to the bedside. The presentation varies, but we often think about whether bleeding or clotting seems to be dominating at that moment.
Right. In really acute fulminant DIC, like severe trauma or an obstetric catastrophe, the consumption, the bleeding phase, often hits first.
What are the classic signs then?
You look for diffuse bleeding from mucous membranes, petechiae, easy bruising, nosebleeds, and that really characteristic sign, persistent, slow oozing from IV sites, venipuncture sites, surgical wounds. It just doesn't stop like it should.
And if it gets worse?
It can escalate quickly, hematuria, significant GI bleeding, and the most feared are the major internal bleeds, intracranial hemorrhage, retroperitoneal bleeds. Those are immediately life-threatening.
Okay, that's the bleeding picture. What about the other side, the microvascular occlusion, the thrombotic phase? You said that's more typical in SIC or chronic DIC.
Yes. There, you're looking for signs of small vessel blockage. Things like dusky fingers or toes, digital ischemia, skin necrosis, or the really dramatic and terrifying purpura fulminans. That's a rapidly worsening septic thrombotic emergency. You often see bilateral adrenal hemorrhage, massive areas of skin dying off. It's classically associated with things like meningococcus sepsis. You might also see patterns like livido reticularis on the skin or early gangrene of the extremities.
But the biggest impact of the clotting phase might not be visible on the skin, right? It's the organ damage.
Absolutely. That's the critical consequence. The organ dysfunction comes directly from those microthrombi cutting off blood flow and causing ischemia. You see acute kidney injury, acute respiratory distress needing ventilation, basically multi-organ failure.
And chronic DIC from cancer might look different again.
Yeah, much more subtle sometimes, maybe recurrent DVTs or PEs, or just vague symptoms. The bleeding risk is often lower because the body has had some time to compensate, even though the process is still active.
With such varied presentations, we really need objective criteria. The IST overt DIC score is the standard now, right? Helps turn suspicion into something more concrete.
It is. The IST system needs two things. First, you need a condition known to precipitate DIC, and second, you need the characteristic lab abnormalities. It calculates a score based on 4 common lab tests: Generally, a score of 5 or more points means overt DIC.
Let's break down those components. Knowing the thresholds is key for using the score correctly.
Okay, the 4 are platelet count looking for thrombocytopenia, prothrombin time, or PTINR looking for prolongation, fibrinogen level looking for a low level due to consumption, and finally, D-dimer or other fibrin degradation products looking for elevation.
How does the scoring work, especially for D-dimer? It seems heavily weighted.
It is, because D-dimer reflects that ongoing fibrin turnover. A mild elevation, maybe less than 3 times the upper limit of normal, gets 0 points. But if it's moderately elevated, say 3 to 7 times normal, that's 2 points. And if it's really high, more than 7 times normal, that's 3 points.
So it's designed to catch the really severe activation.
Exactly. And similarly, the points for platelets and PT increase as they get more abnormal, reflecting the severity of the consumption.
And it's important to remember the ISTH criteria aren't just for overt DIC. They also talk about that early subclinical phase. And there are even modified criteria for specific situations, like diagnosing sepsis-induced coagulopathy earlier.
Right. So looking at the labs overall, the classic pattern is low platelets, prolonged PT and aPTT, low fibrinogen, and that very high D-dimer. But like we said, you have to interpret these based on the phase.
In that explosive bleeding phase.
Labs will be dramatically off. Really low platelets, fibrinogen maybe less than 1 gram per liter, PT-aTT way prolonged. It signifies massive factor use.
But in the thrombotic phase or chronic DIC?
It can be less dramatic. Platelets and factors might not be quite as low. Fibrinogen can even be normal or slightly high because it's an acute phase-reactant inflammation drives it up.
So fibrinogen can be tricky to interpret.
It can, but the one thing that's almost always consistently profoundly elevated in significant DIC is the D-dimer. That reflects the ongoing fibrin turnover regardless of the phase.
Which means you can't just check labs once.
Absolutely not. Continuous monitoring is essential. Calculating that ISTH score serially, maybe every 24 to 48 hours, is crucial. Studies clearly show that a rising score is strongly linked to increased mortality risk.
Beyond the standard labs, you mentioned advanced diagnostics like point-of-care ultrasound or viscoelastic testing, VET.
Yes, tools like ROTEM or SonoClot. These give you a much faster, more global picture of how the blood is actually clotting, which you just don't get from a simple PT or INR.
So real-time information, especially useful in trauma.
Exactly. VET looks at several things simultaneously. The time it takes to start forming a clot that tells you about plasma factors, how fast the clot builds and how strong it gets that reflects platelet function and fibrin linking, and crucially, it measures clot breakdown or lysis.
So it can pick up hyperfibrinolysis quickly.
Yes, which is a major problem in early trauma. If VET shows rapid clot breakdown, you know immediately you need an antifibrinolytic like TXA. Or if the clot strength is poor because of platelets, you give platelets, not just FFP. It allows for much more targeted therapy.
And there's some evidence for its use beyond trauma.
There is, although it's still emerging. Some studies using sonoclot-based approaches in moderate sepsis or heat stroke have shown potentially better outcomes and fewer transfusions, likely because you can tailor therapy much faster.
Okay, let's talk differential diagnosis. It's so important to distinguish true DIC from things that look similar, because the treatments are vastly different and getting it wrong is dangerous.
Absolutely. Probably the most common mimic and the trickiest sometimes is severe liver disease or acute hepatic failure. The labs can look surprisingly similar: prolonged PTINR, low fibrinogen, low platelets.
So how do you reliably tell them apart?
Context is crucial. Acute liver failure usually means coagulopathy, like an INR over 1.5, plus encephalopathy in someone without pre-existing liver disease. And fundamentally, the problem in liver failure is decreased synthesis of clotting factors, not massive consumption.
So the D-dimer wouldn't be as sky high?
Generally, no. It can be elevated in liver disease because clearance is reduced, but usually not to the extreme, rapidly rising levels you see in florid DIC. Also, liver failure typically doesn't cause that microangiopathic picture with schistocytes on the blood smear.
We also need to rule out simpler things, like vitamin K issues.
Right. Vitamin K deficiency or being on too much warfarin will prolong the PTAP-TT, but that's an isolated deficiency of specific factors, 2-ES, 9X. You don't see the widespread consumption, the low platelets, or the super high D-dimer of DIC. It's a much cleaner picture.
And in the ICU, especially after trauma resuscitation.
Massive transfusion coagulopathy. You pour in fluids or blood products, you dilute everything, platelets, factors, so the patient bleeds and the labs look deranged. But the key difference is the history, its dilution, not the underlying systemic activation and microthrombi formation that defines DIC.
Okay, now for the really critical mimics, the ones you absolutely cannot miss because they need specific urgent treatment. The thrombotic microangiopathy.
Yes. TTP, thrombotic, thrombocytopenic, purpura, and HUS, hemolytic uremic syndrome. These are high-stakes diagnoses. They typically present with low platelets, evidence of red cells shearing those schistocytes on the peripheral smear, and organ damage, often kidney injury.
Why are they confused with DIC, and what's the key difference?
The confusion comes from the shared features: low platelets, microvascular injury, organ dysfunction. But the underlying mechanism is totally different. TTP-HUS are primarily about platelet clumping and vessel wall damage, not systemic activation of the coagulation cascade with factor consumption.
So the key lab difference is?
The lack of severe consumptive coagulopathy, PT and aPTT are often normal or only mildly affected in TTP-HUS. And critically, they LS the pathognomonic, extremely high D-dimer levels that are characteristic of DIC. DIC is about fibrin generation, TTP is about platelet aggregation.
And TTP has a specific test.
Yes, TTP is caused by severely deficient activity of an enzyme called ADAMTS13, usually less than 10%. Measuring ADAMTS13 activity is essential if you suspect TTP, because the treatment is plasma exchange urgently. Giving platelets can actually make TTP worse.
Another critical one to exclude: heparin-induced thrombocytopenia, HIT, especially with thrombosis.
Right. HIT also involves low platelets and clotting, but it happens after heparin exposure. You differentiate it based on the timing, usually 5-10 days after starting heparin, the presence of specific anti-PF4 heparin antibodies, and the fact that HIT is almost purely thrombotic. You don't typically see the significant bleeding risk of acute consumptive DIC.
So if the picture is muddy, you need specific tests.
Yeah.
ADAMTS13 activity for TTP, HIT antibodies, maybe even antiphospholipid antibodies to check for other prothrombotic states. Don't just assume it's DIC.
Absolutely critical to get the diagnosis right.
Okay, moving to management. Let's start with the absolute foundation, the non-negotiable first step.
Treat the underlying cause, promptly and aggressively. DIC is secondary. It won't get better until you fix the trigger. This is more important than any transfusion or specific drug.
So that means finding the source of sepsis and controlling it, draining pus, pulling infected lines, or in trauma, stopping the bleeding surgically, damage control. Or for APL, starting specific chemotherapy immediately.
Exactly. That's priority number one. Only then do you move to supportive hemostatic therapy, which needs to be tailored. Is the main problem bleeding right now or thrombosis?
You mentioned earlier that the guidelines for transfusions in DIC are mostly based on consensus, not strong RCT data. Why is that important here?
It's important because while we obviously give blood products to actively bleeding patients, there's very little proof that just chasing lab numbers and transfusing prophylactically without bleeding actually improves survival in DIC.
So just correcting the PT or platelet count on paper might not help and could even harm?
Potentially. You're giving procoagulant factors back into a system that's already massively hypercoagulable. You risk adding fuel to the fire, potentially worsening the thrombosis, especially if bleeding isn't the dominant issue at that moment. It's a constant balancing act.
Okay, with that caution in mind, what are the generally accepted transfusion targets for patients who are actively bleeding or need an urgent procedure?
For platelets, the usual goal is to keep the count above 50 times 10 to the 9th per liter. For plasma factors, we typically use FFP, fresh frozen plasma, aiming to keep the PT and aPTT less than about 1.5 times the upper limit of normal.
And fibrinogen often gets hit hard in consumption.
Yes, fibrinogen is crucial for clot strength. We aim to keep it above 1.5 grams per liter generally.
You can use FFP, but cryoprecipitate is a more concentrated source of fibrinogen, so it's often preferred to avoid excess volume.
But if the patient isn't bleeding, stable.
Then you can often tolerate lower numbers. Maybe a platelet target of 20 to 30 times 10 to the 9th per liter is reasonable if there's no active hemorrhage. All right, now the tricky part, anticoagulation. Using heparin in someone who might bleed seems risky, but sometimes necessary if thrombosis is the main problem.
It has to be very selective. Low-dose heparin, either unfractionated or LMWH, might be considered for patients with clear evidence of major clotting, like a documented DVT or PE, or those with extensive skin necrosis, like purpura fulminans, or just overwhelming microvascular thrombosis.
But there are strict safety criteria.
Absolutely. You generally would not anticoagulate if there's significant active bleeding, if the platelet count is very low, say under 30,000, or if there's concern about CNS bleeding. If used, UFH is often given as a continuous infusion at low doses, maybe 300 to 500 units per hour, with close monitoring.
What about standard DVT prophylaxis? Do we hold that in DIC?
Not necessarily. Standard VTE prevention, usually with LMWH, should generally continue in critically ill patients unless they develop active bleeding or their platelets drop below that critical threshold, like 30,000. Preventing VTE remains important.
Let's touch on those adjunctive therapies, the ones aiming to directly modulate the cascade, like antithrombin or protein C. They haven't panned out well in big trials, have they?
No, unfortunately. Agents like antithrombin concentrate, activated protein C, and even recombinant thrombomodulin. The large RCTs have consistently failed to show a mortality benefit across the board.
And some even showed harm.
Yes, the antithrombin and APC trials raised concerns about increased bleeding risk without clear benefit.
Why did those big trials fail? Seemed promising conceptually.
It's likely multifactorial. Maybe patients were enrolled too late when irreversible organ damage had already occurred. Maybe the drugs only helped very specific subgroups that were diluted in the large trials. Trying to globally tweak the incredibly complex and volatile coagulation system in DIC just proved too difficult and potentially dangerous.
You mentioned recombinant thrombomodulin might have a niche role, particularly in SIC.
There's some suggestion of that, mostly from studies in Japan focusing on sepsis-induced coagulopathy. Thrombomodulin works differently. It helps restore the natural protein C pathway. Some data hint it might reduce mortality in certain very thrombotic septic patients, but it's not definitive enough for broad recommendations yet. It needs more validation.
So regardless of these specific agents, the bedrock of care for these incredibly sick patients comes down to excellent ICU support.
Without a doubt. DIC drives organ failure. You need top-notch critical care. Managing kidney failure with dialysis if needed, supporting the lungs with ventilation, managing shock with pressors. It takes a real multidisciplinary team, hematology, critical care, the primary service, all working together.
Okay, let's wrap up by comparing the different forms again, focusing on prognosis.
Right. Acute DIC, the rapid, severe, consumption-heavy type you see in shock or trauma that has the highest risk of severe bleeding and rapid organ failure. Mortality is high, often driven by how quickly irreversible organ damage sets in and whether the underlying trigger is controlled.
Contrasted with chronic, compensated DIC.
That's usually more gradual, often linked to cancer. The body compensates somewhat, so factor levels might be closer to normal. Fibrinogen might even be high. The main presentation might be recurrent clots or mild bleeding. Here, the prognosis is really tied to the underlying malignancy more than the DIC itself.
And then there's that specific phenotype, COVID-19 associated coagulopathy, SIC-C.
Yes, KIS was and is a very distinct thrombotic form of DIC, driven by the intense inflammation and endothelial injury in severe COVID. The labs were often unusual compared to classic DIC, very high D-dimer and fibrinogen, but platelets often relatively preserved early on, and aPTT not always very prolonged.
So not so much consumption, more pure hypercoagulability.
Exactly. The risk was overwhelmingly thrombotic, lots of PEs, DVTs, strokes, MIs, and developing overt DIC in a patient with COVID was a very bad prognostic sign, indicating severe systemic inflammation and hypercoagulability.
So, pulling it all together, what's the final word on prognosis?
Acute DIC remains the most dangerous, with those mortality rates often in the 30–40% range, sometimes higher. Across all forms, the key predictors of a worse outcome are the severity markers. How bad is the organ dysfunction, how severe is the bleeding, and how deranged are the labs? Very low platelets, very prolonged PT, extremely high D-dimer. Those paint a grim picture.
So the consistent message seems to be, DIC is dynamic, it has phases. Job one is find and fix the trigger. After that, supportive care needs to be highly individualized, maybe guided by VET if you have it, focusing on whether the immediate threat is bleeding or clotting.
Precisely. Treat the patient in front of you based on their current clinical picture and trajectory.
And that individualized need really highlights a persistent challenge in the field, doesn't it?
Yeah.
You mentioned the lack of strong RCT data for many supportive therapies, relying instead on consensus.
Right. The big trials often failed because DIC isn't just one thing. SIC is different from TIC, which is different from malignancy-associated DIC. Lumping them all together in trials hasn't worked well.
So that leaves us with a question perhaps for you, the listener, to consider. Given the difficulties in doing huge RCTs in these diverse critically ill patients, how do we move beyond just consensus? How can we develop truly personalized, evidence-based targets for replacing factors or platelets in specific situations like SIC or TEC? We need strategies that optimize clotting when needed, minimize bleeding risk, but also avoid worsening thrombosis or causing transfusion-related problems. Finding that truly personalized approach, that seems like the next frontier for managing this really devastating syndrome.